All right, y'all. So for the next part of the neurological exam, we're going to focus just on what you do for the cranial nerves.
Cranial nerves.
You want to get a close-up shot of this? Cranial nerves. One is olfactory. In the neurological exam, we don't test that typically. Technically, you could show up with some smelling salts or something, but we never do that. You might ask the patient if they've had changes to their smell recently, especially if you, especially now with COVID. But there isn't really a physical exam portion we do for that much. And then optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. To memorize all of these in order, there is a mnemonic that we love to use. It is O to touch and feel very green vegetables after hours. You can also change the after hours part to heaven.
Just to help get them in order.
And that'll give you the first letter for each of these. Also, it's helpful to think of them as first two kind of have their own locations. They don't like follow clear as easy of a pattern as the other ones. But once you start from oculomotor and trochlear, that's midbrain, and you have 4 pons, 4 medulla. And that'll help you to organize them from top to bottom.
And the reason we're putting their order here is when you're doing the physical exam for the cranial nerves, it can be helpful to try and do it in their actual order. That way you don't lose track of like, am I missing one, if you try to do them in a consistent order each time.
It is totally fine to walk in the room and just take a moment to say, to touch and feel very green vegetables after hours. And then start your exam in the normal order. So, with that, let's go ahead and get started. Cindy is our patient. Olfactory. Do you have any changes to your smell recently?
No.
All right, done. And then optic. Optic has several parts to it. First part, our Snellen card.
We're just using a phone one because like I locked my Snellen card in my car, so apologies for not having a real card.
These are typically designed so that you can have them be at about arm length from the patient. So you can just give it to the patient. Go ahead and have this, hold it right at the full extent of your arm, cover up your left eye. Do you normally wear glasses?
No.
Alright. I am not an optometrist, I am a neurologist, or at least I'm going to be soon. I am less concerned with figuring out what their prescription is, more concerned with figuring out if they have had a deterioration from baseline. So if glasses are their baseline, I'm going to give it to them.
Yeah. If you really want, you can test with and without glasses, but just with their normal glasses or contacts is usually just fine.
Mm-hmm. Alright, if you want to come closer over here. You can see, alright. Of all these lines, read the lowest one that you can.
F, D, P, L, T, C, E, O.
Alright. So you can just go down the line and have them read every single line if you want to be there for the next 30 minutes.
But you don't want to be there for 30 minutes.
If they jump, if I ask them to go to the lowest one that they're comfortable with, if that's already 20/20 and I know that with glasses, whatever they need, that they're at baseline, then I'm satisfied. I might try to push them a little bit to one lower than that, but if it's 20/20, I probably won't. And then I'll hold this, cover up your other eye. I'll hold it at arm's length again. A lot of patients are going to try to memorize what the list is. Some patients are trying to make themselves seem like they're not as sick as they actually are. They might be trying to say what they think the doctor wants to hear. Whatever their reason is, there's a fair number of patients who will try to memorize the test. So a little way that you can make it a little bit harder is the second time. Can you read this backwards this time? Same line that you started from last time, but backwards.
OECTLPDF.
All right, you're reading the bottom, second to bottom one. Can you try the bottom?
DTFCLOZEP or F, not sure.
That was pretty darn close. All right. And so that is the first part of optic nerve. Now, the next part, oh actually I did this again. The next part is going to be looking at their pupils.
Again, because I locked my pen light in my car.
So some things that new students will often do is they will shine a light straight in the person's eye.
That hurts.
That hurts, and they see dots, and it's not fun. A more gentle approach is to come from below or come from the side and just go up to it without going directly in the eye. Also, that's something a lot of new students will do, is they'll just go, okay, and they'll say, we're done. Here's the trouble though. You are not testing the entirety of the reflex if you only look in the eye that you're shining the light in. So it's better to do the swinging flashlight test. What you do is I am looking at this pupil, okay? You want to come in close to see the pupils? And I come in from below, there's going to be a light. I look at this pupil to see that it reacts. I'm still looking at this pupil as I shine at the other eye to see that it reacts either way. So you swing your flashlight between them. And then I'm going to do it on this side. I'm looking at this pupil with the light in it. Then I'm looking at that same pupil with the light in the other eye. And it should have an equal and consensual response. All right, so then, also with optic, comes the looking at quadrants of their field. And for this, you need to have the patient cover their eye so that you're only looking at the quadrants for one eye at a time. And then you cover the same mirrored eye. So because we're facing each other, if she covers her left, I'll cover my right, so that I have an idea of what her fields should be, assuming that I don't have a neurological condition myself. If I have both eyes open, then what I think is a good field could be way off. Whereas if I cover my eye, that is actually a good field. If I have both open, I can see it up here. So that's why we cover our own eyes as well. This is actually, a lot of people will skip it, but it's actually a very important part of the test. You can localize a ton of different lesions just based off of their visual fields. For example, I had a patient who had a totally normal physical exam, except for right lower quadrant synovia, which is the classic pie on the floor, which means he most likely had an issue with his left optic radiations. Based off of, and that was the only physical exam finding that was positive, except for doing some writing with him because he had alexia without agraphia. But that's outside of the normal exam. That was able to localize pretty thoroughly to the right area. And if you find that they have tunnel vision, if you find that they have homonymous hemianopia, all these things are going to tell you a lot about where to localize. So, you cover your eye for me, and I'll cover the same one. When you're choosing numbers for your fingers, your options are 1, 2, and 5. 3 and 4 are too hard to distinguish. Also, a lot of people, for whatever reason, I did it myself when I was first starting, think that it's only a valid exam if you show this side of your hand, and then they end up like doing this. Is that 1 or 2? So you can always do backwards, you can do upside down. As long as you get the right numbers of fingers, what orientation they are in, doesn't matter. Just move your wrist whatever feels natural so that...
As long as it's not horizontal to the patient, so the patient can definitely see
Yeah.
all of the fingers. This, not this.
Alright, now cover your eye, and I'll cover the same. And usually I only give them a brief moment to tell the difference. They only need a second. If I just hold it there, the reason that can be an issue is because they're more likely to flick their eye and look towards it if you give them a lot of time.
And we're testing peripheral vision, so you don't want them to cheat.
Yeah. So, I want you to look straight at my nose. I need them to be looking at the center of their vision so that I'm testing their actual periphery, not testing their, just like looking at it. Alright, so look out straight at my nose, and then tell me how many fingers you see.
1, 2, 5, 5.
Alright, cover the other eye.
1, 1, 1, 2.
Okay.
And then notice how you kind of made a box shape, so you're doing 1 in each quadrant. So like right upper quadrant, right lower quadrant, left lower, left upper. So you want to do 1 of each of those 4 boxes, basically. And you don't have to do any more than that, just 4.
And try not to be predictable. If you do 1, 2, 5, 1, 2, 5, they're just gonna say it was a 2, so next one is probably a 5.
Or if you do notice they start looking at your finger instead of at your nose, feel free to correct them and just say like, look at your nose. You might have to do this several times, especially with like younger kids or something.
Oh yeah.
So yeah, don't feel afraid to correct them because you do want to get a good exam of their peripheral vision specifically.
Alright, believe it or not, all of that was just one cranial nerve. So that's optic. Now oculomotor, trochlear, and abducens are all tested together because they're all eye movements. Can you follow my finger with your eyes and not with your head? If you just say follow my finger, they are doing exactly what you asked, but you will not get the exam right. So follow my finger with your eyes and not with your head. I'll usually go to one side and hold for a bit, slowly go to the other side and hold for a bit. What I'm looking for here is, mostly I'm looking for saccades. As they're moving the eye slowly, it'll flick. Or,
Nystagmus,
thank you.
They're holding it out.
Once they get to the end, it'll flick. Alright, so follow my finger with your eyes. I saw smooth pursuit, and I don't see any nystagmus. And then I'll do the classic H, which is just testing all the different ways that eyes can move. I'm going to have both eyes a D duct in towards the center, at the same time going cross-eyed, because it's, even though technically I've seen them AD duct, I saw the left one AD duct which looks to the right, I saw the right one AD duct which looks to the left, it's easier to see more subtle changes or difficulties if you're seeing both of them AD duct at the same time. So, for example, one of them might partially go while the other one goes all the way, or one of them might stay totally still while the other one goes. But if you are looking to the side, it's harder to tell that there's a difference between my hands right now than my hands right now, or they're their eyes. So I'll have them follow all the way in, go cross-eyed for me, and then down. All right. So that's
One more thing with the eye movement, if you do notice a slight problem where their eyes aren't tracking together, you can hold your finger in a position that you think is abnormal and ask them if they see one or two of your fingers, because if they start seeing double vision, that's a sign that they might not have eyes that are in alignment, so there might be a problem with the extraocular movements.
absolutely. Okay, olfactory, optic, oculomotor, and trochlear, and then trigeminal. So trigeminal, 5-1, 5-2, 5-3, or some people refer to it as V1, V2, V3. The V is just a Roman numeral 5. So, when you're testing for this, there's two different ways to do it. In my previous video, I showed both of them. I wouldn't normally necessarily do both of these, but I just kind of wanted to show the variations. One way is you can have them close their eyes and then ask them to identify where they feel your touch. You want to make sure that you get all 3 branches of the trigeminal nerve. And then another way is to have one side compared to the other. So, and it doesn't matter if their eyes are open or closed in this case. So does that feel the same both sides?
Mm-hmm.
How about there?
Yes.
And there?
Yes.
If this is 100%, how much is this?
100%.
You'll see me do that 100% compare on one side compared to the other side frequently. If a patient says, my right is 100%, my left is 97.5%.
That's normal.
It's 100% on both sides. They're just trying to come up with a new number. You were doing it lighter than you thought on the other side. Some mitigating factor. If it's my right side is 100%, my left side is 50%, that's probably a real thing. Okay, so that's trigeminal. Abducens we already did.
No, masseter is still true.
Oh, you're right. You're absolutely right. So, there's also the muscular portion of that exam, which is going to be masseters and temporalis muscle. So for that, you just ask them to clench and unclench their jaw. You feel the masseter, push your fingers out, and you feel the temporalis muscle moving underneath your fingers. So can you clench and unclench your jaw for me? Okay. Good. All right. I'm not really seeing it as much as I am feeling it. Trigeminal, abducens, facial. Facial is it's going to be motor, so we just want to see how different ways they can move their face. Can you raise your eyebrows up for me? And I might be able to localize a lesion based off of like if they can only lift one eyebrow, if they can, if they're weak when they're doing this, if they have an asymmetric smile, if they have nasolabial folds on one side and far less on the other side. These are the kinds of things I'm looking for. So raise your eyebrows up for me. Symmetric wrinkles across both sides. And then give me a big smile. Everything is symmetric. I'm also looking at nasolabial folds. Okay. And then give me a big frown. Nice. All right. And then also, you can see if their eyes are weak. For example, in myasthenia gravis, it's very common for the eyelids, classic eyelid drooping. You might get fairly normal facial exam and then squeeze your eyes shut for me. Once you do that, you try to pull it apart. And in myasthenia gravis, it might just easily lift up because they just don't have strength left in those muscles. Okay. Vestibulocochlear. There are 2 ways, there's actually a lot of ways to do it. But I showed 2 earlier. One that I usually like to do is I have them look straight out at my nose. And then I hold my hands for doing a finger rub past where I know that they're not going to be able to see the movement of my hand. So I'll hold it a little bit past so that from their perspective, it just looks like my hands without things moving. So look out straight in my nose, and then I'll try to trick them. Which one do you hear it on? How about now? How about now? How about now?
Both.
How about now?
That one.
And now?
That one. That one.
So you can, if you just do like right and then left, that's easy predictable. So I'll do like 3 rights and a left, or I'll do 2 of them together. And even though I said which one, they'll kind of figure out, oh, wait, which one? Don't you mean both? Yes, I do. Okay. And then the other way is you can have them close their eyes and then start from afar and see how close until they can hear it. So just let me know when you hear this.
No.
Okay?
No.
Okay. Testing right and then left, seeing how close you have to get. Glossopharyngeal. For this one, I will have them press against the inner side of their cheek and then feel how strong they can keep that.
And this kind of tests glossopharyngeal and hypoglossal at the same time. Because
Yeah.
hypoglossal is the front of the tongue, glossopharyngeal is the back of the tongue, but you kind of do the tongue all together on the exam.
Yeah. I had a patient who had myasthenia gravis who was in the hospital. We had to do this exam every single day, actually multiple times a day, to check his tongue strength, because typically whenever he lost strength pressing against the inner cheek of his tongue, he was also losing the ability to swallow. That glossopharyngeal helping in the back of the tongue, helping with swallowing as well in the top third of the throat before the vagus takes over.
Leading to the risk of aspiration and choking on food, which we don't want. So that's why it's important.
Having him press his tongue against his cheek every day may have actually saved his life, because it made sure that we knew when to test if he was able to swallow. Alright, so use your tongue to press against your cheek. You can see it sticking out there, I'll just press against that. Good. Okay, press the other side. Good. And then open your mouth and stick your tongue straight out for me. Good. Some people have them move their tongue side to side. You can absolutely do that as well. In my case, I know that she could already press against either side of her inner cheek, so I didn't feel like it's as necessary in this case, because I'd already kind of done that. Then, when you're asking the patients to say ah when you're looking inside of their mouth, you're looking at their palate for symmetric elevation. Let's say that this is either side of their palate. If they have symmetric elevation, it'll look like that. If it's asymmetric, it'll look like that, or that. And with internal medicine, you're typically going to ask for them to go nice and long, because you just want to get everything opened up and out of the way so you can really be looking mostly at the tonsils. In neurology, if you ask them to just go they'll just go and it's going to be a lot harder to see was it that, or was it that, or was it that. So it's a lot better to just ask the patient to do is sharp, staccato, ah. Which shows you a lot better. Okay, so can you open your mouth nice and wide for me? And then give me a staccato ah.
Ah.
Great. Okay. With that, we are on to accessory. So it's going to go to sternocleidomastoids and as well as trapezius. So first, sternocleidomastoids. Can you look with your chin and everything over one of your shoulders? Keep going, keep going, keep going, keep going, keep going, keep going. Good. Anytime you're doing strength, at least anytime I'm doing strength, I become a coach. And I make sure they keep on fighting. Don't just do that and then give up. All right, now the other shoulder. Other shoulder, look over with your chin and everything. Go, 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 go. Good. If you just say look over your left shoulder, well, that's looking over your left shoulder. It's looking over your right shoulder. If you say with your chin, or if you demonstrate, or whatever have you, you gotta say more than just look there. You wanna get everything over. All right, then show your shoulders up. Keep them up, keep them up, keep them up, keep them up, keep them up. Good. And that should do it for the cranial nerves exam.